Good afternoon, everyone. My name is Nicholas Grubik, and today I'll be presenting our systematic review, which investigated the role of bystander-initiated basic life support on exercise-related sudden cardiac arrest. Amongst the general population, it's well known that the provision of CPR and using an AED are essential to maximizing survival after a cardiac arrest. And ensuring that bystanders can perform these maneuvers has been the focus of recommendations and interventional programs over the past 2 decades. More recently, there's been a growing body of evidence investigating the response and outcomes of exercise-related cardiac events among the physically active population. To prevent poor outcomes after exercise-related sudden cardiac arrest, national societies recommend the development of emergency action plans to ensure rapid treatment following these cardiac events. And importantly, the crux of these plans involve early CPR and defibrillation. Despite these strong recommendations, many sport and exercise facilities do not have well-coordinated response plans or resources to efficiently provide treatment after sudden cardiac arrest. And there's ongoing debate on the effectiveness of these interventions in exertional settings, which is mainly due to the lack of research in this area. In order to better understand the available literature on this topic, the objective of our review was to evaluate the role of bystander CPR and AED use on survival amongst exercise-related arrests. In our review, we screened a total of 2,850 abstracts, of which 29 were included in our review for qualitative synthesis. All eligible studies were observational research studies assessing a population of exercise-related arrests where bystander interventions and survival outcomes were reported. And we synthesized study results by calculating the median rates of interventions and survival outcomes among studies with similar patient populations. Amongst the patient populations of our 29 included studies, 92% of exercise-related arrests occurred in male patients with a median age of 51 years, and 78% of patients also presented with a shockable arrest rhythm. We also computed the median rates of bystander interventions and survival among included studies. The median rate of bystander CPR was 71%, whereas the median rate of bystander AED use was 31%. And survival to hospital discharge range anywhere from 11 to 77%, with a median rate of 32%. The figures on the bottom show studies which reported the rate of CPR and AED use according to those who survived a hospital discharge, which are indicated by the orange bars, and those who died after an arrest, which are indicated by the blue bars. We noticed that in majority of studies, the rate of both bystander CPR and AED use was much higher in patients who survived a hospital discharge in comparison to those who did not. Overall, we found that the rate of bystander CPR and AED use was much higher in exercise-related cardiac arrest in comparison to other settings. And similarly, survival rates were also much higher than what has been previously reported in the literature for public settings. It is likely that these positive outcomes are related to a higher rate of bystander interventions in exertional settings, although further registry-based studies are needed to truly uncover this relationship. There are also a few limitations of our study which should be noted. So at the study level, the definition of exercise-related sudden cardiac arrest did differ slightly across studies. So some studies classified these arrests as those which occurred during exercise and anywhere between 5 minutes to 1 hour after an activity. There are also quite a few studies which were missing information on bystander interventions or survival outcomes, although any cases with missing information were excluded from any parameter calculations in our review. We are also unable to include many studies on the basis that they did not report bystander interventions and survival specific to exercise-related sudden cardiac arrest. At the review level, our main limitation was the fact that we are unable to perform a formal meta-analysis due to the heterogeneity in reported outcomes and methodological diversity across the included studies. Overall, our findings advocate for policy changes to improve the cardiovascular safety of athletes and exercisers. For example, these changes could include mandates for basic life support training among those involved in the care and training of athletes, improved availability of AEDs in exercise facilities, and finally, the requirement of emergency action plans to provide point-of-performance cardiac care in exertional settings. Thank you, and I'd be happy to take any questions.